Hamjambo. Hamjambo. So I'm going to share our implementation experience using the Cascaded model that we've deployed in Kenya. So next slide. Next slide, please. Yes, so previously the implementation was done by the HIS partner, but it was not really sustainable given the number of sites that we were supporting. So it was best that we just use a cascaded model to ensure that we have support from the partners and also the counties so that we can scale this up. So EMR upgrades, trainings to end users, that one was taken up by the service delivery partners. And then the HIS partner, that is Palladium, took up the EMR development. So this way has enabled us to reach the number of sites that we've reached so far. So currently we have more than 2,000 facilities that we support, and that would not have been possible if only the HIS partner was the one deploying. So when we cascade that, we also cascade the skills to ensure that we have quite a number of people who have the skills and the capacity to deploy this to all the facilities. So this change has really led to the rapid scale up of the EMR to the 2,200 facilities. So the cascaded approach, it involves that the Palladium team does the indirect deployment that is undertaken through the service delivery partners in the 40 counties that we support, and also just ensuring that we empower them with the training, technical support. We also have the help desk support that we give to these entities. So we develop the system, and then the SDPs and the counties carry out the rollout of these products in all the facilities. This way we have a lot of skills in the 40 counties that will enable us to really deploy in many facilities. Next slide. So this is the model that we used. So we have Palladium there as a HIS partner. So mainly we did the design, development, and the maintenance of the system, development of all the training materials, and we have them hosted in the website, and then delivery of the training to these master TOTs. Then level 2, now we have the service delivery partners. In Kenya, we have 38 currently, and the 40 counties. So this way they provide direct support to the facilities, and also this is just providing linkage between the facility that is in this level and also to Palladium, getting feedback on how to improve the systems to fit the user needs. So this team does that. Then we have this EMR implementing facilities, the 2,200 I mentioned. So these are the primary consumers of the technology. And internal capacity transfer happens at this level that is undertaken by majorly the SDPs and the counties. And then we also have the support requests coming in to Palladium, and also we have the feedback loop to these facilities. Next slide. So this is the approach, how it works. So we have different systems, not just KenyaEMR that we support. We have mobile applications, 5 of them. We also have the National Data Warehouse Repository that we also support, interoperability layer to the different registries also. So the implementation now is taken up by the 38 partners that I mentioned. They deploy, scale up, and use this and train them and mentor the health facilities. Then we have a community of practice. That is a Kenya community of practice, whereby we coordinate with the HIS partners, and also we have this linkage with the OpenMRS, the global OpenMRS. So we have different tracks of communities of practice. We have the student communities of practice, we have developers, and also data use community of practice. Next slide. So we wouldn't have been here if we didn't have that model employed. So for example, currently we have 2392 active EMR sites. Out of this, 2298 are KenyaEMR sites. That's about 96% of that. 80 EMRS sites that we also support, 14 eCare sites. So for 3.x, currently we have 95 sites that are currently running 3.x. And like we mentioned, I think it was mentioned in Monday, that we have also 65 sites running facility-wide. So our target is to ensure that we have all those 2298 facilities running KenyaEMR 3.x end-to-end, meaning that from OPD to all the other services carried out. Next slide. So this is just the team working at the community of practice. Next slide. So I think this is my last slide. So the key benefits of working in that model is the cost effectiveness in implementation and training, because the training happens at the facility level. Increased resources, we have capacity on the ground, and also process efficiencies, you train once and replicate, and design for sustainability. I think this is what the goal that we want to see, ownership from the beginning to the end. Next. So these are just the partners. So parting shot, takeaway, collaboration is a spark that ignites innovation. Alone we can do little, but together we can achieve the extraordinary. Thank you very much.